Our next speaker is Joana Cunha-Cruz. Joana is a dentist and epidemiologist, originally from Brazil, but she's been a Seattle resident for the past several years, and she's been with Precedent for 4 or 5 at least years, and has been crucial in helping get out results from our various studies. There are a number of us who are part-time working on this project and a lot of other things, and Joana has been not entirely on Precedent, but primarily, and has, as a result, has taken the lead in getting publications out from our various studies. So her name's listed on a lot of our publications, so we're grateful for her participation. She's going to talk now about studies that we did on hypersensitivity. We did a survey, as you probably recall, of dentists and what they use to treat hypersensitivity. And then we did a prevalence study to try to get an accurate assessment of the prevalence of hypersensitivity in the general patient population for practices. And that estimate before has varied all over the place, and it depends somewhat on how you ask the question. So we wanted to get accurate data. The idea behind knowing the prevalence and knowing what dentists are doing, we thought we could identify probably the next stage in this, which is likely to be a randomized trial comparing the most popular approaches to treating hypersensitivity, which would be the next stage. So let me introduce Joana Cunha-Cruz, who's a research assistant professor at University of Washington in the Department of Oral Health Sciences. Joana?
Hello? Now you can hear me. So the title of my presentation is My Tooth Hurts, What Dentists and Patients Are Doing About Dentin Hypersensitivity. And I will first define what is dentin hypersensitivity, the diagnosis and treatments that you are using in your practice. And then the main objective of this presentation is to report on a prevalence study that most of you, 37 practices, did it on what is the prevalence of dentin hypersensitivity and associated factors. What is dentin hypersensitivity? It can be defined as a short, sharp pain arising when dentin is exposed to evaporative, thermal, tactile, osmotic, or chemical stimuli, and the pain cannot be ascribed to any other dental defect or pathology. So dentin hypersensitivity is a diagnosis of exclusion. Back in 2009, we did a survey of what dentists are doing to diagnose and treat dentin hypersensitivity. And what came out from that survey is that there are a lot of methods to diagnose dentin hypersensitivity that dentists are using. From spontaneous patient reports, querying the patient about dentin hypersensitivity, applying air blast, water flow, using verbal descriptors of pain, but also using scratching the dentin surface with a dental probe or a curad, and even using electric pulp testers. So dentists are using several methods to diagnose dentin hypersensitivity. And how are they treating dentin hypersensitivity? Well, most of the dentists are using frequently fluorides, bonding adhesives, advice on diet and toothbrushing, but also using office treatments, for example, restorative treatments and potassium nitrate. We also asked you, what are the most successful and least successful treatments that you think? And most of the dentists said that the most successful were fluorides, followed by other treatments, a variety of treatments that was also considered most successful. Among the least successful ones, we can see that advice on diet and toothbrushing was one of the top ones, and also observation or no treatment. It does not work on dentin hypersensitivity. But we also ask you, what are you interested in studying? If you were to participate in a randomized clinical trial, what are the products or the treatments would you like to test? And as the most used treatment was fluorides, it was also the most desired one to study. But also calcium phosphates, glutaraldehydes, and also bonding adhesives. So what did we conclude from this survey of dentists, general dentists? That practitioners commonly relied on the patient to report and assess the presence and severity of dentin hypersensitivity. There were no clear consensus among Northwest Precedent dentists for which treatment is successful, but fluoride varnish and gels had the most support. It was also fluorides that had the most interest in testing, but also glutaraldehyde, HEMA, and restorative treatments were of interest to test. But today, I want to focus on the prevalence study, the studies that were done in practice with patients. This is the report of the dentists, what they are doing. But now we are going to see what the dentists are receiving and what is the prevalence of dentin hypersensitivity. So this is our main objective, is to report on the prevalence of dentin hypersensitivity. Because there are several reports on dentin hypersensitivity that show prevalence ranging from 3% to 48%. But we don't know for sure what is the prevalence. It depends on the setting. It depends on how you query the patient, how you examine it for dentin hypersensitivity. And we also wanted to look at a few risk factors for dentin hypersensitivity. So this was a cross-sectional study done from September 2010 through May 2011. There were 787 participants from 37 general dental practices, around 21 patients per practice. And the objective was to investigate the prevalence and associated factors. Our outcome is dentin hypersensitivity, and I will tell you how we diagnose it in a minute. And our risk factors, we looked at a few demographic factors, also past treatments, scaling in root planning and tooth whitening, signs of aggressive toothbrushing, non-carrier cervical lesions, gingival recession, and obvious occlusal trauma. We did our data analysis using prevalence and prevalence ratios from log linear models taking into account the clustering of patients within each practice. So here is an overview of the design of this study. We selected 3 to 5 half days. They were randomly selected from around a month of the dentist's schedule. Then the dentists were to enroll every patient 18 years or older with at least one tooth, with a minimum of 20 patients per practice. And then the dentist would ask, or the staff would ask the patient with the same verbiage and at the same time of the dental appointment if the patient had. He would ask in this way: have you recently had any pain, sensitivity, or discomfort in your teeth or gums? If they said no, then we assumed that the patient did not have dentin hypersensitivity, or they had a dentin hypersensitivity that didn't bother them. It was not at a level that they would report to the dentist. And then if they said no, they would complete a questionnaire. If they said yes, then we would move on to a clinical exam to exclude other causes of dental pain. And for example, dental caries or periodontal disease, cracks, those were, if the patient had one of those in the tooth that they reported to be sensitive, then we would not consider it as having dentin hypersensitivity. After confirming the dentin hypersensitivity by the exam and excluding other causes, the patient would answer a questionnaire, and then we would assess the pain level. How did we assess the pain level of the patient? We chose to use a 1-second air blast from the air-water syringe to the most sensitive tooth. And then, after applying the air blast, the patient would rate the pain using a verbal analog scale. That's this first one here, that's on one extreme has no pain, and the other extreme has worst possible pain. So the patient would look at this scale and would place a mark where he thinks the pain level was. But we also use the Seattle scales that were developed at the University of Washington to try to understand better the dentin hypersensitivity pain. They were developed specifically for dentin hypersensitivity patients. And it has 4 domains. It has an intensity descriptor that goes from no pain to stabbing pain. There is also duration that goes from no pain, temporary pain, until chronic pain. A COPE scale, from no pain to tolerable and until unbearable. And then a descriptive scale that goes from no pain to shooting pain. So with the Seattle scale, we can have a more complete understanding of the pain that the dentin hypersensitivity patient is suffering. Here are our results. I will be presenting first the prevalence, and I wonder if you have any guess what was the prevalence of dentin hypersensitivity in your dental practice. Do you have any idea? 5%? Okay. So we found out in this sample that was double of it, 12%. From the 787 participants, 315 answered yes to the question, have you recently had any pain, sensitivity, or discomfort in your teeth or gums? From those, which is 40% of the sample, 12% had a confirmed diagnosis of dentin hypersensitivity, 97 patients. They had, on average, 3.5 sensitive teeth. Most of them were on molars and premolars, which I think it's kind of different what we found in the literature, that there is a lot of report on canines. But the most common teeth was molars and premolars in our sample of general dental practice patients. We also asked the patients, have you had any treatment for your dental hypersensitivity? And which treatment was that? 52% of the 12% that had dentin hypersensitivity he received at-home treatments. Of those 52%, 72% had no relief or a relief of less than 6 weeks after having the at-home treatment. For in-office treatments, 22% received in-office treatment. Of those, 57%, half of them, more than half of them, had no relief or less than 6 weeks of relief. But 38%, more than a third, had a relief for 6 months or more with in-office treatments. The most common treatments received for half of them were fluorides, which agrees with the survey of the dentists. What are they using the most? Fluoride. That's what the patients received the most, was also fluorides. But also some of them received dentin adhesives, glutaraldehyde, HEMA, and restorative treatments. What is the pain level of those patients who had dentin hypersensitivity? 11% experienced pain most or all the time. 64% had dentin hypersensitivity for more than 6 months. On the VAS scale, the pain level, the mean was 19.9 millimeters. So in the scale, they placed the mark, most of the, on average, was here, closer to the no pain. So it's a low level, low to moderate level of pain. And we can see in the other scales, intensity, the Seattle scales, the domains of the Seattle scale, that we had for intensity, it was 25 millimeters, which is between dim and a description of pain of dim and dull. For the duration, it's close to temporary pain. The Cope scale, it's close to tolerable, a description of tolerable pain. And in the descriptive scale, the description, it was a mean of 27 millimeters, the highest one, and it was between twinge and ache. So this is the pain level of the dentin hypersensitivity patients. What we can see here is the distribution of all the patients' records on ratings of pain. We have here, for each scale, the VAS pain scale, and then here for the Seattle scales. And you can see that the distribution, most of them are lower than the 40 millimeters for all scales. And I want to focus on the VAS pain scale. If we classify the pain on 4 levels of pain, you see that most of them were, 68% of them were placed a mark between 1 and 39 millimeters of the scale. 16% between 40 and 69 millimeters, and just a few over the 70 millimeter of the scale. So they describe their pain as mostly low to moderate. But we also had 14% of patients who had no pain after the air blast stimulation. So this emphasized the fact that even though the patient had dentin hypersensitivity, they did not experience at that moment, showing that pain is intermittent. Here is the results of the prevalence stratified by the patient characteristics. We have the overall prevalence of 12%, but it varied by age, with increasing prevalence on younger age. So young adults had 16% prevalence, but older adults, the prevalence was 6%. We also had a great variation on those with gingival recession, with a prevalence of 17% among those patients who had gingival recession, and only 5% when the patient did not have gingival recession. And also, statistical significant difference on those that did at-home tooth whitening, 17% prevalence, compared to 10% among those who did not have tooth whitening at-home treatment. This is one way at looking at the prevalence of dentin hypersensitivity. The other way is to look at the prevalence ratio, which we are comparing those prevalence with a reference group. So here, for example, age, we are comparing young adults with seniors, and then middle-aged adults with seniors. On the square here is the point estimate, the prevalence ratio. The horizontal line is the confidence interval, and if it crosses the vertical line, it means that it's not statistically significant. It crossed the line of the 1. There is no difference between the two groups. So most of the risk factors that we looked at cross the line, the 1 line, meaning that it's not statistically significant. For example, race, scaling root planning was not a risk factor. But we can see that young adults, females, and gingival recession were statistically significant, and at-home tooth whitening. What is the magnitude of this difference? So 18 to 44 years old had a prevalence 3.5 times higher than seniors. Females had a prevalence 1.8 times higher than males. Those who had at-home tooth whitening products have a prevalence 1.4 times higher than those who did not have. And the prevalence ratio for gingival recession was 5.5. So we did not find an association of dentin hypersensitivity with evidence of aggressive tooth brushing, non-caries cervical lesions, obvious occlusal trauma, scaling and root planning, and in-office bleaching. Those were not risk factors for dentin hypersensitivity in this population. So a little bit of discussion now. How did we diagnose dentin hypersensitivity? And we think this is a good way to diagnose dentin hypersensitivity. We use a general query waiting for a spontaneous report of dentin hypersensitivity, of a self-perceived, because we are assuming that dentin hypersensitivity should be a self-perceived problem by the patient. So if upon questioning the patient, have you recently had any pain, sensitivity, or discomfort in your teeth or gums, we are assuming that if they say yes, that's because the pain is in a level that's bothering them. So we use the general query, and then we followed up with a clinical exam to exclude other causes of pain, sensitivity, or discomfort. We then assess the pain level, and here we think that the Seattle scale is very helpful to give you a complete overview of the burden of the dentin hypersensitivity for your patient, because it has several dimensions of pain: intensity, duration, cope, and description of pain. And it was specifically developed for dentin hypersensitivity patients. How to treat dentin hypersensitivity? I think this is a big question mark, because based on the literature, the evidence from clinical trials is weak. There are several treatments. We also could see that from the dentist experience, because they are using many, many treatments. On average, a dentist has used 8 treatments for dentin hypersensitivity. And then we also are seeing that the evidence from dental practice based on this survey, on this cross-sectional study, is that the patients are not happy also with the treatment for dentin hypersensitivity. They don't have a long-term relief, either from at-home or in-office treatments. So it would be a very smart next step is to try to develop a randomized clinical trial based on which treatments the dentists think it's most appropriate for treating dentin hypersensitivity. And then I asked you what was the prevalence, and we found that prevalence was 12%, which can be considered by some as a low prevalence, but even higher than some was suggesting, right? So I would ask you if you think that it's a high or a low prevalence. If you had 100 patients in your practice, 12 will be having a confirmed diagnosis of dentin hypersensitivity, which means that out of 8 happy patients that you have, 1 will suffer from dentin hypersensitivity. He will not be very happy. For the risk factors that we assessed, what we found was that women had more confirmed diagnosis of dentin hypersensitivity, those of a younger age who had at-home bleaching and gingival recession. So in conclusion, we can conclude that 1 in 8 patients had dentin hypersensitivity. It affected multiple teeth. It was a chronic condition with symptoms lasting 6 months or more for most of the patients, with an intermittent pain and not very severe pain. And measurement challenge can be addressed by the Seattle scales. And there were no long-term relief from either at-home or in-office treatment for most patients. And with that, I conclude my presentation. And I would like to thank all the dentists and staff who participated in this study, and all Northwest Precedent dentists who also participate in the surveys. And thank you, and I'm open for questions. Okay.
So we're open for questions. I've been asked to, again, remind you, if you have a question, raise your hand, and somebody will bring you a microphone. If you don't use a microphone, we don't pick it up. We're recording this, and then you can't hear the questions if you don't have a mic. So any questions for Joana?
Thank you very much for a very revealing talk for me, who's not a dentist, who's a material scientist. We hope to be able to cure this, one of these diseases ourselves by forming a mineral layer on the surface of enamel. Now, when you gave us your statistics, see, I don't understand very well. When you gave us your statistics, you said that the fluoride treatment actually appeared to cure the sensitivity. We know that fluorine actually replaces carbon, and it makes the mineral harder. It doesn't actually form mineral. So has there been any follow-up studies, even in the laboratory, on simulated studies, applying exactly the same treatment on the tooth, human tooth, and finding out what actually is happening on the surface of the tooth? Thank you very much.
Thank you. So from my perspective, I don't think fluoride, you can say it cured dental hypersensitivity. You can say that most patients who, we don't know yet, but 22% of the patients who had dentin hypersensitivity, they had an in-office treatment. Half of that received fluoride. But we don't know which type of fluoride they received. There are several treatments being offered that includes fluorides. And I'm not aware of basic research on fluorides. I'm sure there are on dentin hypersensitivity, but I'm not aware of those.
You mentioned that there's 12.3%, I think, of the patients that report dentin hypersensitivity. I have two questions. One is related to that number, and just because they're reporting that there's dental hypersensitivity, what's the need to treat that, and what percentage of the people would want that treated? And have they been informed of the consequences of some potential treatment that may be adverse to the retention of their teeth? My second question involves the causes of recession or the causes of dentin hypersensitivity. And one of the causes that seems to me to be prevalent among patients that have more recession than others is prior orthodontic care. Did you look at that?
So the first question again, sorry. If they get it treated. So I think you need to combine the prevalence is 12%. Of those, a few receive treatments, not all of them. And I think you need to address that based on the pain level of the patient, and also if it's a concern for them. And of course, explaining all the treatments that are available and the risks for that. As for the gingival recession related to orthodontic treatments, we did a systematic review on that topic of if patients with orthodontic treatment, if they have more periodontal disease. And we did find more gingival, more recession on patients with orthodontic treatment. So I think you are correct on that, that maybe it's orthodontic treatment that's driving those gingival recession, and mainly in the young age patients. That's what we found also, that dentin hypersensitivity were more common in young patients.
Another question here? Yeah.
So on the use of fluorides like at-home use of fluoride, if they keep using that, does the reduction in sensitivity persist, or does it taper off? Did you evaluate that?
We didn't evaluate specifically fluorides treatment for at home. We don't know which treatments they use at home, but from the finds that we have, it seems that it doesn't last. At-home treatments doesn't last. There's no relief after 6 weeks.
My question pertained to the method you used to evaluate pain, which was 1 second of an air blast. And in that time, I note some patients have sensitivity on the gingival area, but sometimes occlusally if they've worn through the enamel. Not sure if in 1 second, if you tested, if different areas of the tooth could be tested. And the other question is that some people who have sensitivity of this sort, it's not just brought on by an air blast, but maybe having eating something with sugar in it, or acidic things and stuff like that. So I'm not sure why your criteria just evolved a 1 second air blast, or if that might be something that could be expanded a bit.
Mm-hmm. I think this is the most common used method for diagnosis dentin hypersensitivity. That's the one we chose. And I think the scales also were developed based on air blast. But I agree with you. We can see from our finds that 14% did not have a response, a pain response to the air blast, but they did have dentin hypersensitivity. So probably it will be other stimuli that would be initiating the pain with sugar, like you said, an acidic beverage. And regarding the question on if you could apply the air blast to different regions of the tooth, I would like to ask Marilyn, our lead research coordinator, to answer that question.
The way that the practitioners were calibrated, or the instructions were to apply it, a 1 second air blast from 1 centimeter, and that is the same technique that was used when the Seattle scales were developed. So it was essentially the same technique. Does that answer your question? So you didn't direct it to different, sorry?
Could you apply it for the gingival or
So it would
to
be
the occlusal side?
1 centimeter from the buccal surface, essentially, of the sensitive tooth. Okay.
One more question here.
My question is, do you do any combination? Like, I've done glutaraldehyde and like a fluoride varnish, and I've had the patient switch to a Sensodyne toothpaste if they're using an abrasive toothpaste like a whitening or a tartar control. So, I mean, were any of those things evaluated? Because my patients seem to report, you know, some reduction in symptoms. I don't think there's any elimination of symptoms, but at least some reduction when they do that. And they generally, I mean, because I like to follow up and find out, you know, is it working?
Yeah, I understand. Yeah, we have this information because from some of those who received at-home treatment may also have received in-office treatments, but we didn't combine that. We can look at it for the paper, or maybe I can get back to you later on that. But it seems that seeing how many treatments dentists are using, like on average 8 treatments, so it seems that it's a very common strategy to combine treatments. Yes, Don?
So Joanna, I just need to get something clear. Very nice presentation, by the way. So if you had to profile these patients, if a patient came in and you wanted to profile an individual that was at greater risk, what would they look like in terms of?
I think it's, we didn't evaluate the many risk factors, but the ones that we evaluated, we could say that it's a woman of young age that had at-home bleaching and has gingival recession.
Okay.
Basically, it's this the main profile.
Okay, so if you go back to Dr. Deo's presentation, it seems though many of the studies they did were actually looking at patients that were high risk for certain things and then identifying those individuals and modifying the risk factors. And in this case, how many could be modified?
Yeah, I think in this case you can prevent gingival recession, and probably it may, we didn't evaluate that, but it seems that orthodontic treatment may be related to that, and then that's why you explain age and gender in this population, but also at-home bleaching. It's maybe using too strong bleachings.
So you could develop some guidelines for people that do use home bleaching that fit this profile, that maybe caution them about certain potential outcomes. Is that?
Yes, I think we could focus on the at-home bleaching, but I think you need to do more research to make sure what is happening. A good way to do that is looking at patients who received at-home bleaching on a randomized clinical trial and see what's the prevalence of tooth hypersensitivity on those. Would be a good way to start to base your recommendations.
Okay, one more quick question, unless there's another one. So it's always refreshing to have a basic scientist in the group ask a good question. We've always thought, at least my thinking has been, that the sensitivity was in some way related to dental tubules that were open, and
Yeah.
to be calcified and so forth. I guess, is that somewhat of a prevalent thinking? Okay, so just for our basic science colleague, maybe that's something that needs to be looked at. Either we're wrong in making that assumption, or there's something else going on. So that's just a statement. Thank you.
One final question, I think, over here.
I'm not sure exactly how to frame the question, but it seems like between the orthodontics comment and the occlusal wear comment and the gingival recession, there's even though it seemed low on the scale of what people thought was a cause as far as dentists, that there's an occlusal issue that's not being looked at, that's probably an overall or maybe a bigger impact on it. and that the gingival recession is probably more, or the bleaching is more of a side effect of somebody having gingival recession and then putting bleaching agent on that recession that goes directly onto the exposed root surface. So, and what we see then is a short-term fix, and some of this stuff works, but it always seems to go away because the overall occlusal issue of moved teeth and exposed root surface has not been addressed. And I don't know if that's a question or something that you need to look at, or that seems to like maybe, I don't know, maybe I'm off the mark, but it seems like it's something that's being missed. Occlusion.
I would agree with you, yeah.
Okay, thank you very much, Joanna.
Thank you.